Now, training in endoscopy and training in ERCP needs technical skills, but it also needs cognitive competency. And a representative definition for successful cannulation these days is selective and deep cannulation of the common bile duct in a native papilla, and this in more than 80% of the procedures performed. However, a trainee needs also to get familiar with cognitive competence, and this is identified as indications and alternative diagnostic techniques. And also, they need to become familiar with other basic procedural techniques like sphincterotomy, stone extraction, stent insertion, and tissue sampling. In technical skills, a very important topic in this is the initial positioning of the duodenoscope, and then do a proper evaluation of the papilla. One needs to get familiar with scope maneuvering and the use of the elevator. Then, of course, there is the art of cannulation, the common bile duct more in the 11 o'clock position and the main pancreatic duct more in the 2 o'clock position. And within technical skills, there's also the need for to have these skills in performing sphincterotomy, stone extraction, stent insertion, and tissue sampling. Cognitive skills are well defined and listed in this paper. We are not going to go over this list in detail, but there's the appropriate indication for ERCP, and these are quality indicators in ERCP. And I will just focus on the priority quality indicators for ERCP, defined as the frequency with which ERCP is performed for an appropriate indication, the rate of deep cannulation of the ducts of interest in patients with a native papilla without surgically altered anatomy, the success rate of extraction of common bile duct stones smaller than 1 centimeter in patients with normal bile duct anatomy, the success rate of inserting a stent in biliary obstruction below the bifurcation, again in patients with normal anatomy, and the rate of post-ERCP pancreatitis. This is just an example of a topic in cognitive skills. In this study, they evaluated trainees in a serial way every 50 procedures, and as one would expect, the success rate increases and the failure rate decreases while doing more and more procedures. And we see that there's a turning point from becoming successful after doing 150 to 200 ERCPs. However, the cutoff of 80% of successful cannulation of the common bile duct in a native papilla, and that's a very important thing to mention, that it's about a native papilla, this is only reached after doing 350 to 400 ERCPs in this study. So this is a list of studies that looked at competence, when competence is achieved, and in fact it's really the paper of Firma where they looked at a successful cannulation with a cutoff of 80% in a native papilla, and then we see that they come out with a number of 350 to 400 ERCPs. However, nowadays the focus has changed to achieving milestones, and there's also more attention to individual progress. So in this study, 15 trainees performed 1,541 ERCPs, of which 624 were done in a native papilla, and they used a self-evaluation tool. In this study was the Rotterdam Assessment Form for ERCP, which is shown here. And as a result, we see that common bile duct cannulation is achieved in 80% of the situations after 150 procedures. But on the right side of this slide, you see that there is a great variability between different trainees. However, if they looked at the cutoff of 80% for a cannulation of virgin papilla, we see that it is not achieved after the performance of 200 ERCPs. Assessment tools has become available since a couple of years, and I think they are really great tools to make our evaluation more objective, more complete, and it also gives us the possibility to do it in a reproductive way in time. So in these assessment tools, we really look at all different topics, indications, technical skills, but also cognitive aspects. And at the end, there is an overall global assessment and recommendations for the next procedures. This is an example which is called the TSAT, the EOS and ERCP skills assessment, mainly used in the US, I think. However, the British Society came up with a DOPS assessment tools, which is DOPS standing for Direct Observation of Procedural Skills, which is a very similar breakdown of the procedure in all different aspects, like cannulation, indication, and basic therapy. Also, the grading system is well defined, so it makes it very objective.
How do you teach the fellows to cannulate? What technique do you use?
I used to, for the couple of cases I've done, is to do the movement outside of the papilla to be sure which way it will go. And then, yeah, not...
Do you start only with the wire, or...?
We were discussing cannulation techniques, and I was wondering what people are being taught here. Is it purely wire, or is it a combination of cannula and wire? Do you touch the papilla with your cannulotome?
Yeah.
Okay.
Yeah.
Do you do it different?
No, I have roughly the same. But of course, there's not a real definition of wire-guided cannulation. And that's some people think wire-guided cannulation is just only the wire and don't touch the papilla with your device. And other people say, well, if you don't use contrast as a primary means, that's wire-guided cannulation. But yeah. I prefer also to put the tip of my sphincterotome or cannula in the orifice. The problem is that, of course, the more sharper the sphincterotome is, the more traumatic it gets. So you need to be, and these sphincterotomes, they are quite sharp, so you need to take care. It is easy to create a false route.
So we indeed
I'm losing,
make contact with the sphincterotome. I mean, we touch the papilla, but it's of course extremely important to be very gentle, because this will only once, especially for a trainee, I think it's very important to know that you have to be very gentle with the papilla, bring it in the desired position first, and then touch it gently. And we go for the guide wire guided cannulation. So in general, we don't inject contrast. It's also recommended to not inject contrast.
Distance, and then I go to the pylorus, try to see something. Okay. And they taught me that I have to go for the undergoing sun. So
you do it very well. Can you explain it, or is it?
So
and so we have a winner of the quiz. Do we know the name of the winner? It will be on the screen. Michiel Mark. He's the winner. Congratulations.